Welcome, friends, to another episode of CNS Live. Before three very important conferences open this month and next, the 10th Asia Pacific AIDS and Co-Infections Conference, APACC 2025, will be opening in Tokyo, Japan this week. The second Asia Pacific Conference on Point-of-Care Diagnostics for Infectious Diseases, POC 2025, will be opening in Thailand next week. And the 13th International AIDS Society HIV Science conference will be opening in Rwanda next month. So we have amongst us who have insights which are very, very relevant for the agendas of all three important meets happening this month and next is Dr. Prapti Gilada-Toshniwal. Dr. Prapti Gilada-Toshniwal, welcome. Welcome, Prapti.
Thank you so much.
Thank you. So as many of you may be familiar, Dr. Prapti Gilada-Toshniwal is a noted microbiologist and has contributed not only to HIV co-infections, comorbidities, but also you would have been familiar with her name in context with antimicrobial resistance, or AMR, which is among the top global 10 threats worldwide, and all of us are at risk of AMR. A simple injury can lead us to very dangerous consequences if we are dealing with the antimicrobial resistant bug. So this is not about AMR. We will be talking about HIV and co-infections and other issues from Prapti, and we will definitely request her to spend more time on AMR in our future sessions. Dr. Prapti Gilada is the CEO and Consultant Microbiologist at the UniLabs Diagnostics in Mumbai. This specializes in diagnosis of infectious diseases along with other routine testing. And she's also a consultant microbiologist and infection control consultant at Masina Hospital Trust, Mumbai, and infection control consultant and the Punya Shlok Ahilya Bai Holkar Head and Neck Cancer Institute of India, or HNCII. She also has serves as the independent director at Thyrocare Technologies Limited. And her CV is really long. She wears multiple hats, a very humble personality as we have known her over the years. So welcome, Dr. Prapti. We are really looking forward to hearing your insights on something which a lot of us perhaps may not be associating with other than women, and that is HPV. I think programmatically also we need to focus more or broaden the scope of the program. But so over to you to listen to. First of all, let us begin with your opening remarks on and then we will go to the study which you are going to present at the APACC 2025. But perhaps first an opening statement on HPV, or human papilloma virus infection. Over to you.
Yeah, thank you so much. Firstly, thank you for that very kind introduction. So just coming directly to the point, talking about HPV, or the human papilloma virus, and we all, I think for so many years, everyone knows about HPV, but we always associated it with cervical cancer. So we know that HPV is known to cause cervical cancer, and there is a lot of awareness now amongst women and amongst the population, more so I would say in the urban cities, about the regular HPV screening that needs to be done for women above 35, 40 years of age. They now know that along with just a regular pap smear, it's also the HPV DNA test that needs to be done. And the government is taking its steps to spread the awareness about that, as well as HPV vaccination being now made compulsory and getting it under the universal schedule. What I think is missing in this whole thing is a lot of us are not aware that HPV can also cause other cancers other than cervical cancer. So it does cause oropharyngeal cancers, it causes anal cancers, penile cancers, so in fact, HPV is known to be one of amongst the infection related cancers. HPV is known to be the first cause, for all the infection related cancers globally. Like in females, cervical cancer is common. Amongst male, it's the oropharyngeal and anal cancer that is most common, again caused due to HPV. And I don't know, recently in about 2023, there was a Lancet study after which it hit the headlines, that 1 in 3 men are positive for HPV. And I think after that, we did get in a little, people getting concerned and people being aware. But I think that's gone down again once, it died off and it's gone. So yeah, that's basically the thing, that it's not just cervical cancer, it's other cancers as well that HPV can cause, which we need to dive into.
course. Yeah. Yeah. Thanks a lot for this very important overview, Dr. Prapti, because it is really important not only to, of course, we have to prevent cervical cancer. Of course, we have to, prevent HPV infection because it is preventable. Vaccines are now available, and the screening tools are so sensitive for almost all high-risk genotypes of HPV. Even indigenously, Government of India has announced indigenously developed HPV molecular test on TrueNat HPV HR plus, I think, on
Yeah,
16,
the high
18,
risk.
31, 33, 35, for like all genotypes. This is just so important, like the technologies, local technologies. We already have these machines, and of course, there are other machines deployed elsewhere too. So we have the screening tools. We have indigenously developed vaccine, right? Like now the
Yes.
serum perhaps has
Now
come
I have
up
the
with a
vaccine,
vaccine.
which is
Yeah,
available.
and really these delays perhaps should be eliminated too, like in terms of when the things come out, which are evidence based, well validated, and by the time they start getting rolled out. But that is the public health. We really need to find those solutions so that we can have an impact. So. And I was reading somewhere, and please correct me if I'm wrong, I think it was at the WHO, that cervical cancer is the only cancer which we can fully, completely eliminate. And that is why governments, is it true now? That's
Yes,
right.
it is. So,
Yes.
so because it's said that almost 95% of the cervical cancers are caused, around 90 to 95% are due to HPV infection. And because we know it has a vaccine, we feel we can completely eliminate those HPV related cervical cancers.
Right. And now we have such good screening tools, of course. And so
Obviously,
yeah,
yes.
so it's very, very true. It makes so much more sense to do way more. So now going to your presentation, which you're going to present at the upcoming 10th Asia Pacific AIDS and Co-Infections Conference, APAC 2025 in Tokyo, Japan, later this week. So tell us more about it.
Yeah, I'll just tell you about our study. So we are basically an infectious diseases center, also dealing a lot into sexually transmitted diseases. So we get a lot of patient population who come up with different kind of sexually transmitted diseases. When we started, like in about 3 to 4 years, we realized we were also getting a lot of men who have sex with men, who, other than the known just HIV and maybe syphilis, were getting other sexually transmitted infections, namely HPV. There was chlamydia trachomatis, there was gonorrhea, which we've all read. We all know they were all a syndromic approach that when we talk about sexually transmitted diseases, but we were not really testing for all of them. And because we were getting a huge population of the MSM, the men who have sex with men, and we started screening them for HPV as well, because we know that globally HPV vaccine needs to be given to men as well. It's not just women, even though now under the government we are mainly focusing on women, but it's also for the boys and the men. Uh, and that's what we are basically presenting here. We have a group of 105 men, MSM men, who we've tested for HPV to find what is the prevalence like for HPV, and the results that we had were really surprising. So amongst these 105, we had about 70% of them who were HIV positive as well. And the overall HPV prevalence was 62%, which was surprising. I mean, we know there are a lot of studies have been done, and they talk about a prevalence of anywhere between 30 to 40%, or in some cases 50%. We had a 62%. And like it is known in literature, HPV 16 was the commonest. commonest strain that we found. And in HIV positive, it was 68.5% HPV positivity. So even though it was 62% overall, amongst the HIV positive, the prevalence was even higher, and it was about 48% in the HIV negative. Uh, and then we further went down to, because we ran them on GeneXpert, we know that we could find out the strain. So it was HPV 16 or 1845 and the other high risk HPVs. And amongst the HIV positive, like I said, we had HPV 16, which was the highest. I'm just going to tell you the numbers. It's 58% that we had either HPV 16 or 1845. And we had 40% with HPV 16 alone. And we had about 8% of our patients, our MSM patients, who were co-infected with 16 and 1845, which was again, because all those three are the most common high risk HPV that we would be seeing, and there were co-infections also. And and in HIV negative, it was 20% of them had 16 along with other high risk HPV. And most of our patients, our MSM, who were enrolled were from Mumbai. So almost 80% of them were from Mumbai, and we had a rest of them for other cities of Mumbai, and about 3 of them were from abroad. Yeah, from out of India.
Okay, wow, this is really very, very important, information, and especially data. So these were the patients. Like, I'm just surprised to see so many of them, 70%, right? If I could, were HIV positive, right? So is it because they were coming at HIV clinic, or is it because they were coming from a high risk group like MSM? Can you just help us share this information?
It was both.
Yeah.
It was, I think, both, because we are a center who are dealing with, HIV, people living with HIV for over 35 years now. But we are also seeing a change in the patients that we now come to us. So it's not just HIV, it's about other infectious diseases. It's about those who have had some kind of high risk behaviors. Like I said, these were the MSM group, so they were in that high risk key population. So even with HIV, they had HPV and other co-infections as well. So they had, some of them had syphilis, some of them had chlamydia trachomatis, gonorrhea, so those infections as well.
Yeah,
But
thanks.
even overall, like our global data also will tell you that a lot of these MSM population, the HPV is higher amongst the HIV positive MSM than in the HIV negative MSM. Also, in amongst the MSM, the percentage of those with HIV positive are again higher. That's because of the risk-taking behavior that's involved.
Right. Yeah, thanks a lot for helping us all understand this, the context. And all right, so about HPV, like, just please help us educate, like, so far what we have been hearing from PLHIV groups and in conferences, that women with HIV are at a very high risk of HPV, I think 6 times, if I remember correctly. So is it also true for MSM and other men, other gay men, or
yes, it is. So it's overall with HPV. So basically, because like I told you, it's all, again, because it's all sexually transmitted. And also once you have HIV, it just predisposes you to other infections as well. So it is like in women, it is in men as well, that again your HPV is more common amongst the HIV positive population.
Yes, thank you. So this is really important to know. So that is why you are recommending, and of course, governments also are probably moving towards screening everyone, right? Not just women and girls, but all men, and especially high risk.
Not yet really moved to screening men, but that's something that after this study, and it's something we should be looking at, is screening for all men maybe, but definitely those at risk, because we know the population that we can target and we can screen. The other thing is, like when we are spreading awareness about HPV vaccination for women, I think we should just talk about overall HPV vaccination, because that will help. Because even if it is positive for one particular strain of HPV, we still know that in a quadrivalent or a nonavalent, there would be other 3 or 8 other strains that we can still, help our people with. So HPV vaccination, again, important. Another very important thing is, like we know for women, once they are HPV positive, they go through a procedure called colposcopy, where they actually look at the cervix, and they look at the intraepithelial lesions to find, what is the lesion like, and when you go in for a pap smear and then a biopsy to look in for what is happening in terms of the cervical cancer. That's something that also needs to be done for men for anal actually go in and see any changes we are. There are hardly any facilities that really do high resolution anoscopy. So that is another area we will have to really work on, where we develop facilities for high resolution anoscopy. Again, it comes with its own challenges overall. HRA, one, the equipment cost is very high. It needs a facility which is dedicated to, anoscopy. It has a learning curve. So for people who are, the doctors who are actually going to do an anoscopy will need to go through that training, and then it has its own learning curve to be comfortable with, visualization, and if they have to do on-site ablation, then doing that. But I think we will reach there. It's just about, if these 3 things about screening, vaccination, and HRA facilities. If we focus on that, we will be able to go a huge way for HPV in men as well.
Yes, yes. Thank you. Thank you for, helping, at least foresee what should be happening now, based upon science and evidence now. And also now we have tools like vaccines and screening tools and treatments, and, like we should definitely be doing that. And also governments have promised now to end cervical cancer by 2030. We will come to that. Uh, just one quick question is that those who were diagnosed with HPV related cancers or infection, so was there any follow-up required for the or linkage to care?
We are still following up our patients, because we've just taken up the patients up till December 24, and we will be following them up. We've had about one case of, where, so HPV is known that, even though some of them they turn out to be negative in their eventual testing. So that's happened with one of our cases. So we will be following them up. Like I said, we're still looking for a HRA facility easily available, where our people can actually go and get themselves, a scopy done, so that we actually know what's happening. But we will keep them under follow-up. We have also started vaccinating, all those who come to us. We give them the option. We tell them that this is what the data is saying. And I think most of them are okay with getting vaccinated as well. So we are vaccinating them.
Yes. Thank you, because this is really important, and it will again, your center has been a game changer in many ways, path breaker. So I think, as governments and all, especially governments, because we really need government programs to step up around the world, and as they start looking at cervical cancer and HPV beyond women and engaging others, so perhaps this will also be a very important piece of evidence on how to actually roll out these programs and evidences. So thanks a lot for sharing. Any closing statement, any final thoughts, and also about any reflections, insights on the promise by the governments, thankfully worldwide, to eliminate cervical cancer by 2030.
Yeah, so I think the things cancer was very, very. Hello, sorry, did
Hello.
I lose you somewhere? Sorry.
Sorry, Prapti. I think the connection dropped. Uh,
Yeah.
so can you just repeat the full thing again? Yeah, sorry.
Yeah. So I was just saying, I think the focus was started off with cervical cancer because the numbers, in terms of numbers, we are seeing many more cervical cancer cases caused due to HPV in terms of numbers than actually anal and oropharyngeal cancers. So that's the focus there. But I think at the same time, both the things can be done together, because if we are anyway engaging our tools into screening women and vaccinating them, the same thing can be done, for men, and especially the high risk population. So, because the screening tools are going to remain the same, we have wonderful screening tools available now where testing can be done within 2 to 3 hours. So, they're all point of care assays where tests can be done at the site and the reports can be available on the same day. Vaccination earlier was much more expensive. Now, with our indigenous vaccine, the cost of vaccination has come down. So I think that that can be freely available anyway. So it's just about spreading the awareness, both in the population, and also strengthening our government policies in terms of just making HPV an agenda for men as well. Yeah.
Yes, I totally agree with you. And let us hope that this happens sooner than later. We really need to do everything possible to prevent infections that are preventable, and of course, diagnose as early, accurately as possible. It's about all multi-diseases, and of course, linkage to care. And you will be knowing already, I'm sure, that the World Health Organization is already came up with a draft of multi-disease elimination approach, and it was in for public review till last month, till 31st of May. And let us hope that really gets operationalized so that more integrated responses become a reality. So thanks a lot, Dr. Prapti Gilada-Toshniwal. Really insightful to listen to you. All the best for the upcoming 10th Asia Pacific AIDS and Co-Infections Conference in Tokyo, Japan. All the best, and of course, all the best to all your insights and work, which is going to provide scientific evidence to the governments to perhaps consider, broadening the scope of their response to eliminate cervical cancer and HPV-related cancers, and do more, because it is possible to do more with tools and approaches which are very much developed, and the science which is being developed from the global south, which is right here. So all the best. Thank you.
Thank
Safe
you so much.
travels.